Started. Today our research conference is consisting of a journal club that one of our clinical informatics fellows, Dr. Amilia Drace, will present. Dr. Drace is in the Clinical Informatics Physician Subspecialty Fellowship. She is a physician by training, went to undergraduate at Stanford and medical school at Washington University in St. Louis, did a residency in pediatrics and pediatric neurology at St. Louis Children's Hospital, and then we were fortunate enough to have her join our fellowship program. And so this will be a journal club presentation. Maybe I'll let her describe how she's going to run the session, and we'll go from there.
All right, thank you very much. Today we'll be discussing psychosocial information used for clinical decisions in diabetes care. I'd like to keep things pretty informal, so I feel like discussions are generally better when they happen when you think of a point, so please feel free to just raise your hand and we can talk about something on a slide that's confusing or that you object to or that you'd like to put some perspective on, and so we can just, don't be shy, let discussion happen where it may. So, just for some background, psychosocial information, aka social determinants of health, is basically anything that a clinician should have or has to identify where patients might have issues in terms of adhering to a care plan, accessing care, accessing medications, etc. So the things that the physicians usually find that annoys them are the lack of self-care behavior. So we usually have those frustrations in terms of, they're not eating right, they're not showing up to get their labs drawn, they can never come to clinic, all of those things. And so the framework that this paper is using is looking at that as a combination of both personal factors and environmental factors, and then assessing how different clinicians approach those in their decision-making and practice. So social determinants have been recognized for a while as a useful and important component of clinical care, so they have been rudimentarily included in the EHR, but there's still a long way to go as far as how standardized they should be. So there is some movement towards getting those put in as LOINC codes. We're nowhere there yet. And as far as how to manage those reporting and how to incorporate community service referrals are still very much kind of a new field, and part of what this paper is trying to look at is how do physicians actually use this data, so how should we support those workflows. So we don't really know how we should incorporate some of that information, so if someone has housing insecurity, food insecurity, etc., should that show up to the clinician as some sort of summary view? Should that guide any additional prompts for resources? Do different members of the care team, say social worker, a clinician, nurse practitioner, etc., need different information, or would they make different decisions based on the same information, and who's going to step on whose toes? And then it's also kind of unclear, one, what physicians are actually doing with the social determinants of health information, and two, what they should do. So this is looking more at what they are doing in the current state. So for their model issue here, they chose type 2 diabetes, which is a pretty good model for social determinants of health evaluation. For one thing, it's extremely common and also has a very strong correlation in its clinical outcomes with race, income, education level, and then some other issues as far as physiologically that make it so important to interact with the social determinants of health, and probably why those correlations are so strong. For one thing, you have to have regular monitoring, so if there's an issue with affording labs, getting transportation, having a regular phone number, all of those types of things can interfere with that. Refrigeration can be a huge issue if you have housing insecurity or your electricity is getting turned off. We dose all of this based on your expected habits with your carbs. And if you don't have a stable source of food, it's kind of difficult to maintain how many carbs you're getting at any given time. And so we see generally a lot of long-term sequelae, diabetic retinopathy, vasculopathies, peripheral neuropathies coming from long-term undermanagement of diabetes and high hemoglobin A1Cs, which will kill you, But unfortunately, if you try and control people too tightly and they don't have a social situation where that is something that they can do safely, they don't have family members that would notice if they're acting a little loopy, if their sugar is low, if they don't have a stable enough source of food, so if you keep their blood sugar low and they're getting hypoglycemic, they don't have access to a candy bar or an orange or whatever to boost them back up. So if you try to overshoot or you try to treat someone who doesn't have a stable living situation as though they do, you can bottom them out and kill them. So that's obviously unpleasant. So this was a mixed methods evaluation. Started off with a qualitative portion and then kind of codified that into a quantitative portion as well. So it started out with semi-structured interviews. They took 17 clinicians. They tried to get kind of a broad look at how often each of these people had been practicing in a variety of locations, and just said, if you tend to deal with type 2 diabetes in the outpatient setting, and if your practice includes economically marginalized people, we'd like to talk to you. And then they started with 3 physicians who were close to the investigators, and then kind of proceeded in a snowball manner with 14 additional physicians from their practices. And then once they kind of decided they had reached saturation with that classic qualitative approach, we're getting all of the same information over and over again, so they decided it's time to move forward and go to the quantitative. So from those themes, they used a grounded theory approach. So they looked at what the transcripts of the interviews were saying, devised some themes, devised some codes for those themes, and then kind of coalesced some of those themes into a few larger, higher level themes. They looked at a quarter of the responses and had another rater go through them for inter-rater reliability. They found a 98% agreement, so that's pretty good. So they felt like what they're coding makes some good sense. And then they also pointed out they did some cognitive interviews, which they didn't clarify that much in the paper. When they had written their survey questions based on the information they'd gotten from their surveys, they then did some in-depth interviews to see whether or not those survey questions made good sense to people. Apparently the cognitive interviewing technique is most common in forensic interviews, which doesn't seem particularly appropriate. But what they were able to do is basically guide people through and ask more probing questions as far as what their thought process was on reading the interview questions that they had devised. And from there, the clinicians were able to say, well, at this point, I think it would be helpful if you asked about a medication change or adding brand name versus generic, et cetera, so that they kind of refined their surveys before they went out to the whole group. And then for the quantitative portion of their study, they did an online survey. They looked at a number of different providers. So they had MDs, nurse practitioners, and then diabetes educators, who consisted of both registered nurses and registered dietitians. And the way they got these is that they had some access to various listservs that they basically said, hey, here's the survey, please answer it. Their participation rates were actually pretty good, as you can see from the percentages. Sorry, that's crazy small. But they got about 19% response rates for the nurse practitioners, 30% for the educators, which in survey land is very, very promising. Pretty even split between gender, and then most of their interview participants were fairly young. Over half of them had less than 10 years of experience, and then a few were older. And then in the final survey responses, they had about a third 10 years, a third 11 to 20, and then a third kind of over 20 years. Of the docs, they had family medicine, internal medicine, endocrinology as the most commonly represented, and then they had a few endocrine emergency medicine, but those people are either less likely to be seeing at-risk populations because more wealthy people can afford specialists, or if you're a hospitalist and so on, you don't necessarily see people in the outpatient setting, which is what they were looking at here. So the stats that they used for the quantitative portion, they looked at a one-way ANOVA between differences of clinician types. So they had their groups: are you an MD, are you a nurse practitioner, are you a diabetes educator? And that will show whether the whole group is significant. And then they had Tukey's honest significant difference post hoc test, which in their paper they called honestly, but which basically looks at if you have an ANOVA that says the whole difference between groups is significant en masse. The Tukey's test is designed to say, well, which of those groups are the ones that are actually driving those differences? So it basically goes through a bunch of pairwise comparisons, so physician versus nurse practitioner versus diabetes educator, physician versus diabetes educator, and sees whether those are significant. And then they did a Bonferroni for multiple comparisons corrections. So the results for the interviews, they basically looked at which things clinicians were looking at in terms of how they wanted to assess what patients could manage. The big themes was the patient able to manage their own personal life, finances, getting to appointments, and so on? Were there environmental issues, housing insecurity, difficulties with transportation, et cetera? Did they understand their treatment? Were they able to access and afford treatment? Were there any other barriers to self-care, like including mental health? And then a lot of physicians, especially in the more at-risk practice settings, talked a lot about kind of being mindful of the reasons for noncompliance or non-adherence. And then for the group that were community health clinic providers, there was that group was much more likely to consider it a matter of course that their clinician interview should always take into account social determinants of health, and that they would incorporate that regardless of any red flags. That's probably some kind of rudimentary, Bayesian intuition that, the baseline probability of people in these clinics needing extra resources is so high that those providers have adapted to getting into that workflow that you just always have to ask. In other settings, providers were less likely to say, oh, I always look for social determinants of health. So they would consider, if a patient wasn't well controlled on their diabetes, then they would say, well, now I have to look at what might be going wrong. If they knew of any social determinants of health complications, they would ask about them in their follow-ups, and if they had any additional comorbidities, especially mental health concerns. Whether or not mental health gets classified as a medical comorbidity or a social determinant of health can be very controversial and can differ across what the paradigm is for any given study, so it's kind of worth keeping in mind how that is classified. And then any life changes. So for instance, if someone gets divorced, loses their home or anything like that, loses a job, has to move, those can dramatically change their ability to keep up with their diabetes care. And so clinicians endorse that they are mindful of those things, but not all of them had an a priori look to say, we're going to screen for those proactively. So most providers said if we're doing a new diagnosis of diabetes, that is usually a trigger point for discussing social determinants of health, kind of to counsel that patient through how their ongoing medical management is going to change and become a lot more intensive over the course of that care. And then kind of the big things that providers had to think about and decide were, do they think patients can manage an insulin regimen? And that means, can they manage it cognitively? Do they have access to a refrigerator? Do they have access to a regular supply of food? Is that going to change? Can the patient afford insulin, and which insulins can they afford? So there was a recurring theme of just using the very generic 2-hour insulin as opposed to some of the more novel analogs that can be short-acting and long-acting and combined, which would probably get better A1C control, but a lot of those patients couldn't afford that, so they had to decide, what can we offer that will be feasible? And then in terms of what they would decide the target glucose for that patient should be, some patients needed to be more permissive because they were going to have such variability in that target, similarly to the A1C. Also, patients would describe, well, if I'm feeling really down or tired, or I feel out of it and I can't work if my sugar is too low, et cetera, that would affect kind of how they were able to practically manage that plan. And there was a lot of discussion of, needing to support the patient in perhaps a less mathematically, medically perfect glucose and hemoglobin A1C management in favor of coming up with a plan that they could feel invested in and actually contribute to and cooperate with. And then the other question is, if we devise up a really complicated treatment plan, is this patient going to be able to understand the instructions and additionally carry out those instructions? The other big prompt for social determinants of health was if the patient needed a referral to psychiatry or to any other social services, community groups, food banks, et cetera. So then, based on that, they set up a quantitative survey. From there, they got 6 different modalities of social determinants of health that they looked at. So those were financial strain, mental health status, life stressors, food security, health literacy, and social support. And what they were looking at, the leftmost bar in each of these is the total, followed by physicians, nurse practitioners, and then diabetes educators at the far right of each cluster. So you can see overall the physicians tended to be the least engaged with how much they were asking about social determinants of health. These are done on a 6-point Likert scale, as you can, actually 5-point Likert scale, but 6 is just hanging out up there. But you can see most people tended to understand financial strain as a pretty common thing to ask about. Food security was the least engaged with from the physicians, which does kind of make me worry, since this is a disease process that is so intimately tied with what you eat and when and how often. Fortunately, the dietitians, the educators were pretty good at asking about food security, so that's somewhat reassuring. But you can see across the board that the physicians tended to be less engaged, although they were still endorsing like a 4 on a 5-point qualitative scale. So they were still relatively engaged, but just not as much as ancillary staff. This is a reworking of Table 3 because I objected to how they provided it in the paper. So what they looked at is, would providers ask about social determinants of health in all circumstances when there were chronic issues and when there were new circumstances and when those circumstances changed? What they had initially reported was, of those who had asked patients about their multiple chronic condition, what percentage were primary care providers versus nurse practitioners versus diabetes educators, which I did not find made intuitive sense in terms of what the frequency and how those care providers responded. So what I've done instead is looked at, of the total number of primary care providers, nurse practitioners, and educators, how many of them asked these questions and in what circumstances. So you can see overall the uptake is pretty good. 81% of physicians, 87% of nurse practitioners, and 84% of diabetes educators would ask about social determinants of health in all circumstances. As a caveat, of course, this is a pretty enriched population for physicians who are going to be aware of these kind of issues, just because part of the inclusion criteria was that they were aware that they were treating patients who were more likely to have obstacles, and they're the people who would care enough to join into this survey. So I'm sure if you asked a garden variety unsampled primary care physician group with a different socioeconomic balance, you probably wouldn't get 81%. And then from there, they were also looking at those who would ask about those issues in chronic or new circumstances. I did have some questions in terms of how they calculated this out, because the in all circumstances and chronic circumstances is greater than 100% when you add them up. And even just one of them, for instance, all circumstances plus patients with multiple chronic conditions, which means that obviously the percentage can't only be those who didn't ask in multiple chronic conditions, but logically, if it should be additive, and some of them are asking in all circumstances, you either have to have a number that is less than or equal to 100% minus 81, or you have to have a number that is greater than 81%, depending on how you are setting up your questionnaire and how that logic is going through. So I think the way that these stats are falling out indicate that some providers are saying, I ask in all circumstances, and they either didn't ask or they didn't answer the follow-up survey questions, or they interpreted that as asking specially or taking extra care, whereas other providers seem to answer both the all circumstances and some circumstances, because that's the only way that I can get the math to work out unless someone disagrees with me. But you can see some of the common issues that they're seeing are patients who are very complicated, who have poor adherence, who have either diagnosed or undiagnosed mental health issues. I wonder about the primary care physicians because, unfortunately, that's a relatively low number, but if you think someone has a undiagnosed mental health condition, you're their primary care provider, I would hope you'd make some efforts towards getting them diagnosed, but that doesn't always happen. I just flat out don't like this table. Yes?
So practitioner has a
Oh, lovely.
that I was just going to share. So his comment is in the methods they use their sampling strategy is initially networking and then maximum variations sampling. And so he says that maximum variation sampling is a method that researchers use that selects usually at first a small number of units or cases that maximize the diversity relevant to the research question and is commonly used in clinical informatics.
Thank you. All right. So here we have basically every possible variation of medical decision-making all graded on a 4-point Likert scale, and apparently it's crucially important that we have standard deviations on every single line because I think that really adds to the understanding. Wouldn't you agree? So the 4 broad terms that we're looking at, and this is, please don't read this. This is only here for me to complain that I just don't like the visualization. But the main issues in terms of what medical decisions will be made based on the information from the social determinants of health work, what the target level of control is. So where do you want that patient to be aiming with their glucose, their hemoglobin A1C? Do you make any recommendations such as for dietary, physical activity, additional caregiver support, follow-up times, et cetera? How you select medications, whether they are orals, insulins, whether they're brand name or not, et cetera. And then whether or not you make referrals, for instance, to specifically diabetes-based management or additional community support services, other specialty care. So again, this is on a Likert scale, so never, kind of, sometimes, mostly, always. You can see that overall people are pretty much at ceiling. There's a general preponderance of high 3s and low 4s throughout all of these. So that shows that people are overall kind of engaging with this issue, and they perceive from self-report that they're doing that rather frequently. That said, I would wonder whether or not this Likert scale is capturing enough granularity in terms of what people are answering to justify this level of drill down for the topics when your outcome measure is admittedly fairly crude. So the only ones that they endorsed as being statistically significant were if you'd make physical activity recommendations. Again, they did do a Bonferroni, which is fairly conservative in terms of how it restricts for multiple comparisons. And overall, you can see that the diabetes educators endorsed being relatively more likely to make changes in their decision plans with patients based on social determinants, and the physicians tend to be the least likely. I think some graphs and scatter plots would be helpful here, but I didn't bother to make one myself. I apologize. And I think it would be interesting to see kind of what those decisions could be across those various ancillary services and how they would approach those. So for our discussion, this was the view that they looked at in terms of what the decision process was. Most providers, and this is mostly from the interview portion, although the quantitative did bear it out, but this is kind of over-enriched for the MD perspective. They looked at, is the patient doing well clinically? And then if the provider thought that they should always ask for psychosocial determinants of health, they would then proceed to ask about them and then use that in their care planning. And then if the patient wasn't doing well clinically, the things that people tended to look at for what could be the cause of either poor adherence or poor numbers or additional sequelae of disease progression would be, is there something chronically going on that's been an issue for this patient for a long time? Is there a new circumstance either related to the novelty of the diabetes diagnosis, or is the patient themselves new to that provider, or has there been a change in that patient's circumstances as far as their outcomes have changed abruptly? They have suddenly stopped caring for themselves as well as they should, which would prompt, has this person developed an unrecognized depression? Have they lost access to either their material or social resources, et cetera? And then once that is incorporated, this model is very charitable. It doesn't include, oh, I asked about it and I found no way to incorporate it. So it assumes that everything gathered here has been used constructively, which I think is very optimistic. So the conclusions that they drew were that RNs and registered dietitians were the most likely to consider psychosocial factors. And providers across all 3 groups we're more likely to be able to take into account individual level social determinants of health compared to community indicators. And the authors pointed out that there is a bit of a disconnect because EHR data tends to be pretty good at pulling in community level social determinants because, you know, they have zip codes and they can pull that kind of information automatically. And there have been some attempts at piloting, you know, a community vital sign type score, something that would look at the patient's, for instance, zip code and say, well, here are some of their baseline risks relative to what demographic information is already in the chart. The trouble is that most providers didn't seem to find that as useful as, you know, are you married? Did you lose your job? Do you have stable housing, et cetera? Obviously, some of those demographic factors can raise your probability of having individual factors affect you. But in terms of what the provider thought they could do as their next step with the community level factors, they seem to have a, you know, not my lane kind of attitude. And then again, most of the providers of MDs, nurses, and nurse practitioners, and diabetes educators did endorse as their common practice that they would always consider social determinants of health. And again, the strongest predictor of that was what practice setting they had, and thus what patient population they were more likely to see. So some limitations that I was looking at. One, I found it a little odd that the qualitative portion was only looking at MDs and then set the quantitative portion to look at multiple different providers. I would actually have really liked to see what were the results of qualitative interviews with the nurse practitioners and with the dietitians, because I think they would have a lot of richness in that perspective. So you're basically establishing what your quantitative survey paradigm will be based on the experience of the clinicians, who happen to be the ones who are least likely to actually ask about social determinants of health. And then you're trying to map the practice patterns of people in other services to those decisions that are determined, you know, by someone else's workflow. So I found that to be a little bit odd, and I would have liked to have seen perhaps one study that went, here's theme generation of physicians, and then here we'll survey physicians, here are themes from the nurse practitioners, or to get themes from separate three groups, and then see if there was any way that they would want to compare and contrast those in a structured interview. But I think they did lose out on some opportunities from limiting what they were going to be investigating based on who their initial population was for their qualitative portion. I also found it interesting that they had different care roles from different states. I think that's just because when they had access to listservs that were able to get them, oh, here are a lot of diabetes educators that we can contact at once, here are a lot of nurse practitioners that we can contact at once, and those listservs were state-based. But I do kind of wonder if we're perhaps getting any noise from the different settings that those people are working in. Either are there differences in education in those states? Are there differences in the culture of those offices? If you asked all MDs, nurse practitioners, and dietitians in one clinic or set of clinics in one community, would you get a different answer? And also, are there differences in terms of what practicing at the top of your license means in those different states? So does that affect what medical decision-making a registered dietitian is making if they're in Michigan versus Texas versus Maryland? And so just because of how they sampled that, that kind of introduces some complexity to their answers that we don't know. And again, I wonder how sensitive the Likert scales are, because pretty much everyone was answering on the 4 to 5 level. I mean, there were a couple of 3s, but you'd kind of have to wonder, are you basically getting a binary outcome between mostly and always? And is that the best way to approach some of this data? And then, like we talked about with the survey inconsistencies, you know, some people were answering, yes, I always ask about this, and then I also ask if there's been a change in their circumstances or if there's a new patient. Some people seem to answer, I always ask about this, and leave the rest either blank or no. So I think there would be some opportunity for data cleanup or exploration in terms of how people were interpreting those questions, because there's no single answering behavior that would explain the statistics that they have. And then I would really be interested in terms of if your dietitian says, oh, well, here's how I would change their diabetes plan based on their social determinants of health, and the MD isn't asking, you know, presumably the person also has an MD involved in their care, if those two treatment recommendations differ, does that go to the MD going, oh, you know, I only have 10 minutes to see this patient. If you say they're not going to be able to make this, sure, we'll do what you say. Or is it, no, I'm the MD and I say he needs to be on this level of insulin? Like, how do those mismatches get accounted for, and how do those manifest in the ultimate care plans? So other things that could be investigated on the same paradigm, like we talked about, having additional care providers participate in the theme generation, I think could broaden the scope of what we're looking at. And then I think the amount of what they looked at for their sample size was appropriate, but with any of these different parameters, we can mix and match them if we had more people to study for any given group. So would it differ by years of experience for people who perhaps had a more modern paradigm of medical education, more attuned to social determinants of health, or would the grizzled folks who have been in the trenches and have learned the hard way more likely to pay attention to social determinants? And then kind of how does the social determinants of health asking, because we have, here are the things they ask about, we have here are the contexts in which they ask, but there wasn't the ability to kind of check for an interaction between those two things. So if you're someone who always asks and then you notice a problem, do you drill deeper? What sort of things do you drill deeper into? If you are asking about social determinants of health because there's a change in clinical status, or you've been made aware that there is a change in a personal situation for that patient, does that guide, you know, the depth and breadth of what you're looking at and how actionable it is? And then which of these domains would actually correspond to better diabetes outcomes? Is one of these more predictive than the other? And then kind of beyond, so those are things that I thought could be addressed from a similar study design, just more patients, some slight restructuring of kind of going more in depth of what they were already looking at. And this would be kind of the next step beyond that is what could we look at in terms of how to optimize what is available within the EHR, and how should that be done to affect social determinants of health capture and utilization. So, you know, multiple enterprise EHRs have tried to have some form of social determinants screening questionnaires or other tools. Is there any evaluation and analysis that we could do that could determine, you know, superiority or non-inferiority of any of those modalities? And then if you're going to base any clinical decision support on the social determinants, are you going to get pushback from clinicians? What is the right point in the workflow to work on that? What kind of alert or other notification or display is going to get your best uptake? If we incorporate some of that decision support, is that actually going to translate into better outcomes? And then what about prompting a more proactive screening? So there were a number of clinicians that said, oh, we assume that everyone's kind of got their lives together, until they seem to follow through the cracks, until they have a poor outcome, and then we look into it. Whereas other physicians kind of had that philosophy of, oh, we should always ask from the beginning and check. Are the people who are always asking more proactive at catching those issues, and is that translating into better clinical outcomes? Or is that just too noisy a system that we can't tell? So we don't know yet. Next is, once we have theoretical framework in terms of the social determinants behavior, the EHR behavior, how could we implement that clinically? So is that something that the physician is going to ask face-to-face? Should that be supported in any type of, you know, workflow artifact like their SmartSet or their Visit Navigator? How should that be recorded? What levels of standardization should we have for social determinants capture? You know, there are some things that are, you know, are you homeless, are you not? That could be binary. Or, you know, how stable is your housing situation? Are you on a friend's couch? Are you on the street? Are you on a shelter? Are you in a shelter? Are you somewhat food insecure? Like, there's so many different ways that you could mathematically conceptualize that problem, even assuming you wanted structured data. And then there's also a situation where there's a lot of value in narrative data, and how should we incorporate that into our EHRs, and in what contexts and for whom? Who wants to see this data and when? A big issue with people who really try to incorporate this data into their clinical workflows is, how do we establish the currency of this data? There can be some provider pushback or some patient pushback if they come to clinic and every time they're there, they have to kind of go through all of the things that are very stressful in their lives. Sometimes they can be very resistant to that, and they're like, you know I've got these hardships, can we move on? But then there's, well, they were homeless last month, are they still homeless? They were homeless a year ago. What do we determine as, copy forwardable data versus how often should we reestablish the validity of that data? Then, social determinants of health have social consequences, being social. So are there any additional privacy measures that we have to take for any of these? And is there any break glass status that we need to think of? Is implementing any of those safeguards going to reduce uptake of the utility of how that information might actually help their clinical planning, and who decides that? And whether or not clinicians can have a closed loop paradigm of, okay, I sent this person out for a referral to a food bank, to a behavioral health center in their neighborhood, et cetera. That often doesn't come back to the EHR very well. I don't know if Nat was able to remote in, but Nat, if you're here, text Brian, because I know he was working on a number of getting that information back to the providers in his clinic, and so he would have some insight in terms of the complexity of that problem and actually allowing that follow-up. Next up, we do have some ethical considerations. So if you are deciding that we'd want a predictive model for social determinants, for instance, for diabetes care, how should we incorporate that into the EHR? Is that something that the provider would find welcome or frustrating? Is that something that would create good anticipatory guidance for a more feasible plan of care, or would it kind of shunt people who are already systemically marginalized into a more fatalistic, well, there's no point in prescribing insulin for you anyway kind of mentality? So is that going to prompt more thorough discussion and better allied decision making, or is that going to close off potential avenues of care, and how should we do that thoughtfully? The next question I would have for some of the answers we got in the structured interview for this paper is a lot of physicians were describing things like, oh, this person's social situation is such that I wouldn't feel safe having them on a very tight glucose control. I don't think they'd be able to manage it. I'd be worried if I put this person on insulin, they'd overdose and die because they couldn't manage it, or whatever else. So I think there's some very important ethical considerations in terms of how much therapeutic alliance should you have with that? Should you tell a patient, here, if we're going to say your hemoglobin A1C is going to be like 9 or 12, here are going to be the long-term risks of that. Here's the risk of, if we control you really tightly, what resources do you have? Is it feasible for you to make these changes in your life, to have regular access to a refrigerator? Could you or should you move in with a family member? Those are pretty heavy conversations, and we know that whenever patients are provided with something that has the correct thing to do would be this, people will often try to please the person who is interviewing them and say, oh yeah, I could do this, or I could try to do that, and possibly, commit to more than is feasible. But on the flip side of that, if the provider is making that assessment for themselves that, oh, this plan wouldn't be feasible for that patient, that person might not have the ability to mobilize resources that they may have or may put a priority on if they understood the true risks of that. Similarly, if the patient says, well, I feel really crummy when my sugar is low and I don't feel like I can take care of my kids or go to work, how much education and awareness is there of the long-term sequelae of that, and how thoughtful is that shared decision making? Do we have, we can have the best predictive model for, this person is unlikely to be able to afford this insulin. What can providers do? What should providers do? What should communities, nonprofits, et cetera, be doing to say, well, this person needs access to long-acting or extremely short-term insulin? Is that being effectively leveraged in some way? And are these tools encouraging that better utilization of resources and seeking out of better resources? Or is it shunting people into second-tier care, which is something I should think of? Should you require a referral to additional social services if you're saying your target hemoglobin A1C is 9? Is that considered an appropriate management plan without requiring some sort of, at least, evaluation of remediation for those issues that are putting that patient into that situation? So, to open it up for questions and comments.
Hi, Amelia. Thanks. That was a great talk. I'm just interested in if you were to look at whether the degree of engagement with social determinants of health, kind of like how that correlates with actual patient outcome, would studying that be complicated by the fact that providers who might be more engaged with social determinants of health might be taking care of patients who have more complicated or severe cases, so you would kind of have to like tease apart those two relationships?
Yeah, you'd basically have to have some means of a provider-independent way of determining what the social determinants of health are. Because if you are saying, oh, well, this person has a lot of really bad predictors, and that's all, if your catchment is all via what the provider is documenting, you're not necessarily catching people who are worse off. You might be catching better providers who are asking for that. Similarly, some providers might be more likely to ask and then document for people who less obviously, or who more obviously don't have their lives together. So if people are taking a kind of a red flag approach, and there are some people in some communities who, if you go to the doctor, you wear your best clothes, you make sure that all of your kids are, hair and ribbons and the whole bit, so that they're very reserved as far as not showing any level of vulnerability. So those people might be much more likely to skip through the cracks depending on what the provider behavior is. So you'd have to figure out, what is your base truth and who decides and how do you catch that? And then how do you deal with the Hawthorne effect for going through and assessing that? What is known to the provider, which is what is the provider's workflow, how well are they documenting what they know, and then what actions are the providers taking specifically based on that information. And assuming you can capture all of those things, you'd have a pretty complicated statistical model to tease it all out.
I've read people asserting that actually the healthcare system is not a good place to collect social determinants of health. That there are eyes and ears out in the community, and to hear some people describe it, some of the big problems are actually getting that into the record so that when it is time for social determinants of health to influence clinical decision making, that information be available there to feed into the kinds of decision support you've described. I'm just wondering if you could comment on how that kind of fits into what was looked at in this study.
So I think from the methodology of this study, they were very much looking at what the providers are trying to seek out and what they value and when and why, which I think is a slightly different question than what you're asking for. What else is known and how else can we get social determinants of health background that might be withheld or unavailable from providers based on community knowledge. I think there's some good points to that. There's some people who have a lot of very understandable distrust of the medical system, and that is going to affect their willingness to engage in care, the amount of information they'll provide, and their trust in the decisions made based on that information. There's also a lot of problems with looking at eyes and ears out in the community. There can be people who significantly disagree about what other people's risk factors are. Certainly in pediatrics, we've had our fair share of one parent will swear that the other person has this or that issue, and that can be very contentious in finding out whether or not that's an actual drug problem or parent who doesn't like the custody arrangement and all sorts of other things. So
yeah, I guess I'm thinking about people who get services out in the community. I was chatting a few weeks ago with someone who works for Moda Health, our insurance company, and who's very interested in social determinants of health, and notes that for example, there's services like Meals on Wheels that go out into these communities and actually gather data. Or they deliver services, but they're in a position to gather data, like I delivered a meal into this person's house, and it's a mess, or you know, it's the middle of summer and they have no air conditioner, you know, things like that. That's, you know, as opposed to, you know, a physician trying to collect that information during a 15-minute office visit. I'm just, I think I am actually asking, I think maybe a way to put it with regards to this paper is actually whether this paper is asking the right question of, I mean, I suppose it's important for clinicians to know, you know, to look at ways that you can incorporate social determinants of health. But, you know, maybe a real question is, you know, when is the right time to do it? And in those situations, how do you actually do it?
Yeah, so there would be a lot of potential applications for some sort of, you know, summary display or dashboard type view, or a, you know, patient summary of, you know, if they've gotten meal assistance, that should show up, or if they have, you know, rent control, or, you know, an apartment building has been condemned, can that get reported to anyone who lives in that zip code, like full extended zip code kind of thing? Plausible. I would be interested to know what the privacy policies and what the consents are for all of those different service providers. So for instance, if it's like a mental health clinic, they would have very strict lockdowns on what they can disclose, and saying, you know, would you like us to provide this information to your primary health care provider? May be welcome in some circumstances, but, you know, if you're in an abusive situation and your spouse has the same primary care provider as you do, like, there's so many different components. So I mean, the general perspective of having a more holistic data gathering for social determinants and having that be available for clinician review, as opposed to requiring a paradigm that asks about these things, I think is a very good point. It would just be really something else to make it work. So.
So I kind of, I had some questions along the same lines of Bill's, I guess, which are, or maybe some comments too, which are like, having worked for a lot of those community support agencies, like, they're pretty badly underfunded, especially compared with healthcare organizations, and also the EHR incentives that are available to, you know, physical healthcare clinicians aren't available for mental health and community agencies. So it does seem a little bit like that would need to come from the healthcare end, like that kind of integration of that information would need to come from the healthcare side rather than from the community agencies themselves.
So, like, not saying, hey, healthcare clinic on the corner, or like behavioral health, why don't you collate all of your different data visits and send them to us, but rather, hey, we as OHSU or equivalent will provide a block grant to do X amount of stuff. That
Right.
It needs to be kind of a bi-directional partnership.
Right. That maybe the agencies could work on, you know, getting consent and figuring out the privacy part, but they're not going to have the resources to actually, like, set up the technology. But yeah, and I guess in a broader sense, do you have any ideas on how we would do that, or how it would work, were such a program to theoretically exist?
So you'd have a question of, you know, what kind of data you would want to capture, how would you standardize it, how would you, because I mean, there will be some overlap between what the mental health care services and the local food bank and Meals on Wheels and, you know, medical call ride will all be able to get their own, you know, piece of the puzzle. There will be some overlap. How do you standardize that so that you can see whether there's agreement with what they're reporting, whether they're giving different answers, but that's appropriate because of what the different facets that they're seeing? How do you present that to the clinician in an easily digestible way? We already know from what these clinicians were reporting that the community level stuff is actually harder for them to make sense of. So it would need to be something that was actually, you know, tagged with a patient identifier and able to say, this particular person, you know, has red flags for food insecurity. Mm-hmm. This particular person has sought mental health care services, or, you know, spent a night in a women's shelter or whatever else. So to make it most useful, it would be the highest level of complexity as far as privacy and patient safety. So that would be pretty challenging. There's also a component that a lot of this is people at multiple levels of community health resources, clinicians, ancillary staff, trying to solve a problem that they're not necessarily in the best position to solve. You know, it is a nationwide social reflection of our priorities that some people can't afford the right type of insulin. And in the paradigm of looking at this and how these clinicians are making these decisions, you know, they're not in the position to call someone up and have that changed or approved. But the decisions that they're making are necessarily a reflection of, you know, national public policy that's saying we're going to make this resource not available to certain people.
Yeah, so that kind of segues nicely into another question I have, which is like, well, how would the information about the social determinants of health translate into treatment decisions exactly? Like, I could see, okay, maybe choose a cheaper medication.
But I mean, even of the example they gave, and like I totally agree with the decisions the clinicians are making in terms of, if we put this person on the mathematically correct regimen in the context of their lives, they could have major poor outcomes, including like death from hypoglycemia. So I think it's a situation of seeing people willing to do a lot of work in their own domains and take on other work that wasn't necessarily what they were trained to do, all with the best intentions, and yet still it is absolutely an outrage that we're not just talking about generic versus brand name medication, we're talking about pharmacodynamically different insulin that is going to have different effects on your hemoglobin A1C and cause different sequelae and potentially poor management and often life-limiting complications because of an inability to afford this medication.
Yeah, so it almost seems like in order for social determinants of health to be actionable, it might actually have to go the other direction, right? Where the physician is telling, you know, Meals on Wheels, hey, could you check in on this person?
Right. And
here's what to look for.
Right. And the infrastructure of that is really not good. And so even getting physicians to be aware of what should be incorporated, like what's in the EHR as far as a refer out to these services, is very rudimentary. Physicians can feel very frustrated in terms of they don't see whether or not that's being effective. So they just feel like they're sending these referrals out into the ether and they don't know for sure whether or not that loop was able to be closed. And unfortunately, when you just keep negatively reinforcing things, you get people who will, you know, try to incorporate that for a little while, see nothing come of it, and give up, even if it was, you know, a useful or helpful intervention.
Yeah. I mean, I know from working in the mental health care system that there was so little support that a lot of times we would rely on the police if we were worried about somebody, because they can do a well check, right? So we send the police to their house. But that isn't the ideal way to check on somebody's health, to send a police officer to their door. But that's kind of like the only resource that's available. Thank you. It was an interesting article.
And we have all these perfectly discrete reported somehow in the EHR, and you're giving PPAs and pop-ups and alerts. And how would you do that in a sensitive manner, but also not bias submission, also trying to ascribe to evidence-based medicine? Because what you're saying is we're going to play this little loosey-goosey, we're going to let the physician make some decisions to allow for a little bit weaker control based on SDH, but we're putting this in writing, we're putting this in EHR. How do you envision that working?
Right. Well, that's why, I mean, this wasn't an ethics paper, but I decided that eventually became a slide in my next questions. And I was like, one other question. Oh, wait, that feels weird to me. No, this is a full slide. We need to talk about this. I think it's much easier to make a case for things like prompting referral to services and making the clinician aware of what services there are. with respect, of course, to the, who has the resources in this situation. It's oftentimes the healthcare system, but comparatively speaking. But is it then the responsibility of someone in ITG to run a complete itemized list of all of the mental health facilities and food banks and so on, that needs to be in Epic, so that when a physician pulls up a, referral to ancillary services, it says, well, here are the local food banks, here are what shelters we have, et cetera, et cetera. Like, that I have an easier time with if that has shown up in an evaluation. As far as an EHR prompting a change in medical management based on social determinants of health, that makes me very uncomfortable. So it would certainly be something that if there was any type of evidence-based way to say, if someone has food insecurity, do we have knowledge of how we should change their insulin management? If there is a known way to do that, that should be accessible to the clinician who is in that situation. However, it's also really creepy that we would invest resources in finding out the best of poor insulin management options rather than investing resources in finding out how to get these people adequate access to food and refrigeration. So, if there was a specific, if you're going to be on 2-hour insulin instead of a short and long-acting combination, can the provider say, okay, we're going to use this treatment plan and start that cascade? You could potentially have some guided decision-making for, well, if you have to kind of step off the beaten path, we have semi-beat out this other path for you and caught a few other things. But I would have a real hard time with having the EHR prompt a provider to say, hey, don't try to optimize their sugars, because that would get into like second-class healthcare, I think.
No, but almost all CDS for an A1C and a blood pressure and everything else gives a context right now, right? And so an A1C recommendation is almost always a range and almost always has variability. And what you can envision pretty easily is it's saying, hey, based on age, this is the range that we recommend, but if you think it should be something else, what are the criteria that you're using to say that? And then have the physician say, hey, I'm picking a different range based on medical comorbidities, based on those data. Then the CDS can say, great, I agree, and here are the resources that you can use. So if you clicked the social determinants of health box, here are, do they have food insecurity, and here are the resources. Do they have drug insecurity, and here are the prescription supports and the groups giving insulin or other medications in the community or coupons that are available, and here are the housing resources, et cetera. And so you can imagine that rather than it being a primary driven different goal, that the
It's okay, we've got a second one here.
He hears me all the time. So every CDS for an A1C at this point in time gives a range. And this, you can just imagine in a place where it has to be a little bit different. And I think exactly what Dr. Kerr said, and I'm laying on your name, but diabetes is often done through a medical home or a broader model. And you made a comment about, gee, are the physicians not asking about diet and food and things like that? But I can guarantee you that the dietitians aren't asking about their renal well, that's not true. They can have a renal diet. But they aren't asking about all the different medical comorbidities. And there's a reason, and how do we divide that up, and what's the appropriate place? Just as Dr. Hirsch said, what's the appropriate place for screening for these things? What's the appropriate way to communicate it between the providers, and what's the appropriate way then to make the medical decisions? And it's a complicated, multi-layered problem that this just kind of touches on.
And it's one of those things where even just very minor ergonomic differences in how the implementation is set up can have really significant effects. So if you have a dietitian at your clinic, so let's say the clinic workflow is the patient comes in, they have a scheduled appointment with a diabetes educator, and then they go to the provider and they have their medical appointment. If the EHR is structured such that whatever the dietitian enters in isn't available to the clinician at that point, that information might not be accessed and decisions might not be made, or the provider might feel that they have to ask again, or they think, oh, well, I'll feel weird asking about this again because I know that my educator just asked about it, but I still can't find it, or it's not clear. And it's, a couple of screens of navigator difference can make the difference between a well-functioning multidisciplinary machine and, balkanization.
No, I mean, as a diabetologist-ish, I make a ton of decisions based on the information that my support team gathers. And when my nurses give me information, it's crucial, and the dietitians and the psychologists and all these people who are playing a role in the team, and there are more and more data saying that we need that team. And then the question is really, how can informatics best communicate that?